Next is Dr. Muralidhara. He is going to present about the childhood myopia key points.
Good morning, and I thank Dr. Santosh Navar and team for having invited me. I'm pediatric ophthalmologist at the Eye Foundation, Coimbatore, and I'll be talking on key points in childhood myopia. So let us first understand the magnitude of the problem. Around 23% of the world population is myopic. It has doubled since the last decade, and the prediction is that with the current mathematical modeling, that half may become myopic by 2050. So in some countries, especially in China and Singapore, Taiwan, almost 70 to 80% of the adults are myopic and 20% of children have high myopia. So it has been labeled as an immediate concern by the WHO for elimination of avoidable childhood blindness. So high myopia not only decreases the quality of life, can also predispose you to cataracts, retinal degeneration, glaucoma, and more than 8 diopters of power implies almost 8 times the risk of retinal detachment, and more than 6 diopter, 14.4 times the incidence of glaucoma as in normal population, and 2.3. So myopia is an emerging problem and it is rapidly increasing, and so I'll just cover some points on this. And the possible reason behind the spike is possibly an increase in near work and less time spent outdoors, less sun exposure, some genetic factors as well, because if the adults develop myopia, the child is also more likely. Reading in dim light, these have been blamed for the spike, especially the COVID lockdowns. They have been blamed as possible reasons for the myopia pandemic. And I'm sorry. So this is kind of a flowchart that we use. So let us say you identify a child at risk of myopia progression, more time spent indoors, and parents myopic, and more hours spent on reading, especially during the COVID pandemic. Almost all schools have made laptops mandatory. So if the answer to all this is yes, it's mandatory. This is a public health education. I would suggest that you can put these videos in your clinics, and you need to act, because myopia is an emerging pandemic and India is no way behind. So if 23% of world population is myopic, India cannot be behind, and so we really don't want to be at the peak of the curve. So evaluation, we typically follow the guideline that if the child is less than 5 years old, we do an atropine refraction once a day for 3 days we give, and CTC is cyclopentolate, tropicamide cyclopentolate. So if the child has some kind of a contraindication, like a history of seizures in particular, or a previous history of cyclopentolate psychosis, we need to train our staff to ask for these leading questions. Does the child have any neurological problems? Has the child had issues with cyclopentolate before? In those cases, you can use homatropine, because cyclopentolate crosses the blood-brain barrier. The advantage is that it has shorter turnaround time, rapidly acting, and the effect usually goes away in 8 hours. Some may have till 72 hours, but homide is slower acting and longer acting also. Effect will be there for 5 to 7 days. So a comprehensive ocular exam is mandatory. So these are the American Academy focal point guidelines. These are for normal children, not for those with cerebral visual impairment, in which case our limits may be lower. So if you have an infant or toddler up to 1.5 diopter of myopia, usually we don't correct. And for preschoolers, they say 0.25. Practically, it's around 0.5 diopters. So these are the upper normal limits. Above 1.5 diopter, if the child has still 1.5 diopters, you don't worry too much. But if the child has something over 1.5 diopters, you have to monitor the children very closely. But if the child has more than 3. So I hope the distinction is clear. These are the upper normal limits, and these are the clinically significant beyond which you would start prescribing. That is more than 3.5 diopters, or preschoolers more than 1.5 diopters, or more than 1 diopter, you usually start prescribing. In fact, school age, you can even do a subjective refraction and do it. These are the upper normal limits, so beyond which you would start monitoring them for myopia. So this routine screening is indicated if there is a family history, if there is a history of prematurity, if there is strabismus or nystagmus, epicanthus, any syndromic associations, and if there is a head posture. All these children, even without visual complaints, need to have atropine refraction less than 5 years, and above 5 years, dynamic refraction, cycloplegic were indicated. So regards to myopia and strabismus, so remember that when you measure strabismus over a minus glass, it always gives a higher value. So this formula I have taken from my mentor Sharma sir's book. This is measured deviation by the actual deviation, and this is the formula. You would find it in Sharma sir's book. And yeah, so this is a central patient who had mild myopia. So note the magnitude of the exotropia.
2, 4, 8, 9.
And when you over minus them, there is some controversy regarding over minus. This is not for everybody. So please note whether they are able to tolerate or not, and only then you should. Come on, madam, I'll change. Okay, with the over minus, the occluder is completely occluding the right eye. It is just that it is not seen very well. So with over minus lenses, the magnitude definitely comes down, especially in those with high AC by ratio. But over minus lenses, there is some controversy, especially on effects in myopia progression. So it is not for everybody. So remember that, and now we'll talk on some of the key things that you may have heard across all over: halting or staggering myopia progression. So this is from the WSPO's consensus statement for 2023. So all these possibly they don't work. So remember, there is a distinction between peripheral defocus and DIMS. So this is available on the WSPO's. It's a free download, and so these interventions possibly they don't work. So what really appears to work is more time spent outdoors, more than 2 hours, and reduce near activity. Low concentration, I mean 0.01% or 0.05% atropine eye drops. And DIMS, and these are highly aspheric lenslet, which is a new, this thing not yet commercially available. Orthokeratology and soft multifocal, these possibly, they would work in halting or staggering myopia progression. So I'll first talk on the DIMS.
This technology is based on the peripheral defocus theory. In the myopic eye, rays are focused in front of the retina and in the periphery behind the retina. With a single vision lens, rays are focused on the retina, while there is a hyperopic defocus. MyoSmart with DIMS technology creates a myopic defocus, focusing rays in front of the retina.
Incorporating the DIMS technology, or I mean DIMS technology is available. DIMS is a proprietary term with Hoya, but Zeiss also makes Myovision, and Essilor also makes Stellus.
This technology.
Okay, so this is the proprietary DIMS technology. There is central 9 millimeter, and then there is 33 millimeter diameter, where you have these DIMS lenslets, and each of which defocus by plus 3.5 diopter, each of which defocus by, I mean, surprisingly, there is no issues in traffic safety, as the company themselves say. And even when you ask our children who are on these DIMS glasses, they do not report any issues with peripheral vision. So, so this myopic defocus, where you make the retinal periphery relatively defocus myopically, possibly it is the likely mechanism of action with ortho-K and multifocal contact lens efficiency also. They are less invasive, so I also prescribe them to pre-myopes. Pre-myopes is the first time myopia. Normally, they were recommended only when there is myopic progression of 0.5 diopters or more in the first 6 months. But in case you have a sibling who is progressing rapidly, or parents having high myopia, I give them even earlier. So the benefit is not known in staggering pseudophakic myopia. So the benefit, this is the benefit, they stagger the progression by around 0.5 diopters over 2 years, and 21% had absolutely no progression over 2 years. So over 3 years and over 6 years, the efficacy of these lenses are sustained. If you thought there was not a very great there was not a very great efficacy, then please remember that even a 1 diopter reduction in myopia reduces the risk of myopic maculopathy by up to 20%. So that's really something, this thing is non-invasive, and there's no issue of compliance, because anyway the child has to wear the glasses. So if the child is younger and lower baseline myopia, so the earlier you start, the more efficacy you are likely to get. And there is a chance of rebound if you switch from DIMS to a normal glass. So possibly you would like to give it as long as it is required. So these are the ATOM trial, atropine and myopia trial. And remember, this was the range over which it was tried, 6 to 12 diopters. This actually gave much higher efficacy than the DIMS glasses. Almost that was a 60% reduction. This is 70 to 80% reduction in myopia progression. So these are 70 to 80%, that's what I said, reduction in myopia progression. There is some rebound. So the idea is you give it for 2 years and then give a break, holiday for another 1 year. If there's progression, you may have to reinstitute atropine. So 0.01% was supposed to have the least rebound, but there are some studies that show that 0.05% is more efficacious, and the rebound is almost the same as the 0.01% atropine. And remember, both in these DIMS as well as these low concentration atropine, there is a certain percentage, 9%, who do not respond to either modality. So whether you can use it in combination or not, we don't have the answers as of yet. Okay, so this is the atom, and basically it showed that the rebound with 0.01% atropine given once night was the least, and sometimes we use it twice in case the patient fails to progress, but whether twice daily application or thrice daily application is more efficacious, and whether a child is going to comply, we do not know as of yet. We don't have answers to these questions. Okay, so this is basically the study findings that show, and yeah, over 5 years the least progression was in 0.01. Remember, it is not about halting myopia progression, it is only slowing it down, and even these children, they progress by minus 1.38 diopter. If you had not, then they would have progressed by around 4 diopters also. So these are the recommendations, and so if there is less than 0.25 diopter progression in second year, you can stop it. Otherwise, you can continue it until the progression stops. And last 2 slides, these are reverse geometry contact lenses. We are yet to gain too much of experience. Possibly they reduce the myopia, but possibly their efficacy in slowing down myopia is same mechanism as these DIMS glasses. So there is a real risk of keratitis with these, but they say the risk is it is slightly lesser than the other contact lenses, but definitely more than the normal population. We don't have answers on rebound, and don't forget the lifestyle modification like daylight exposure and good posture, lighting, reduced near work, and close monitoring. They go hand in hand with technology. And thank